you. Well, thank you for your welcome, Liv, and welcome to all of you who've joined. It's really good to be here. I'm in this role, I'm a parish nurse, so I work for Grace Church Salisbury and really reach out to the people, mostly in Bemerton Heath in Salisbury, and really supporting people with long-term conditions and signposting them and so forth. I might just talk a little bit more about that in the end. But I'm also a practice nurse, and one of my specialities is respiratory long-term condition. And so I want to just talk to you a little bit about COPD. So Liv, may I have the next slide, please? So what is COPD? It's a bit of a mouthful, which is why we say COPD. It's short for chronic obstructive pulmonary disease or lung disease. And it's an umbrella term for chronic bronchitis and emphysema. So that I don't know, hopefully you can see on this slide, chronic bronchitis is where the airways are persistently full of inflammation and also get more fixed. They lose their elasticity. And then the emphysema side of things is where the tiny little air sacs right at the bottom of your airways again lose their elasticity, and air can get trapped there, and that's what causes people to feel short of breath. Next slide, please. So a few statistics from the British Lung Foundation. So it is a huge problem, 1.2 million people living with diagnosed COPD, and probably many more who haven't been diagnosed. So around 2% of the population and 4.5% of all people aged over 40. And there's been an increase of 27% in the number of people who've ever had a diagnosis of COPD in the last decade. That's probably to do with the fact that we're probably better at diagnosing it these days, and rather than necessarily saying that more people are getting it, but we're much better at looking out for the signs for COPD and diagnosing it. But it's the second most common lung disease in the UK after asthma, and I talked about asthma last week. In 2012, 5.3% of deaths in the UK were due to COPD, and you can see the figures there. Okay, thank you. Next slide, please. So causes. In the Western world, the main cause of COPD is smoking, is cigarette smoke. But in other countries, it may well be that there are other reasons for it. For example, in places where people have fires in their houses and they don't have a lot of ventilation, then they may well be more susceptible to getting COPD. Then we know pollution can also lead to it. Occupational exposure in all sorts of different ways as well. And sometimes it can be genetic. There is a gene that people can carry that makes them more susceptible to getting COPD. And sometimes some childhood chest problems can lead to it, but that's more rare. Thank you. Next slide, please. So what are the symptoms? Coughing with sputum, and I'm afraid I do talk with my patients a lot about sputum. The reason being that people have sputum is, if you remember the bronchitis, there's inflammation. Well, that's then what causes the sputum. So that can be quite a problem managing that with people. The emphysema side of things is the one that would be much more likely to cause the shortness of breath on exertion, but some people at rest as well. And then wheezing, particularly in the cold weather, but sometimes wheezing at other times. And sometimes people complain of tightness of chest, but not so commonly. Next slide, please. So diagnosis, the most important thing is really getting what we call a good history. So really good consultation, asking lots of questions about when they were born, whether they'd had any respiratory problems, but also getting a good idea of smoking history and any family history and occupational exposures and all that side of things. Now, I work in some areas with people who've worked in the as soldiers or in the MOD, and sometimes they've been exposed to things that they can't tell me about. So sometimes that can be another cause. So really getting a really good idea of what's been going on and the symptoms that people are complaining of, how long it's been going on, and whether it's variable. Asthma is much more likely to be variable. COPD, the symptoms tend to be the same most of the time unless someone has a chest infection. We normally do spirometry, which is lung function, and I had a lovely colleague who posed for me yesterday to take that photo, so thanks to her. It's the lung function gives us a lot of information, but unfortunately during COVID we've not been able to do that, so we've had to improvise tests that we can get patients to do at home, but it is more difficult to rule out, and sometimes we've had to go with a view of suspecting it. But also a chest x-ray would back us up as well and show some emphysema changes and so on there that would give us a clue. Sometimes blood tests as well can give us a clue, but also rule out other causes of breathlessness like anemia, for example. And we may well check oxygen levels as well, but that wouldn't be the main diagnostic feature. Next slide, please. So treatment, everyone hears about inhalers. Now, there are lots and lots of different inhalers, all shapes and sizes, different devices that we would use. We would normally give someone what we call a reliever. People may know of it as their blue inhaler, but really is what we call a bronchodilator. So that would just open up the airways. It relaxes the muscle in the airways and gives almost immediate relief. So for example, if someone's getting short of breath on exertion, I might say to them, well, if you know you're going to be exerting yourself, you could take your inhaler before, 2 puffs of your inhaler before you do the exercise, and managing it that way. On top of that, if they were needing it a lot, then we would think of long-acting bronchodilators, and they come in different forms. There are 2 different classes of drugs that would act in that way of opening up the airways, and we may give one or the other or a combination of both depending on the severity as well. Later on, if someone's very susceptible to getting chest infections, and this is a recurrent thing that they get, we may well add in an inhaled steroid to actually deal with that and protect their airways a little bit more. But that's usually further on down the line, and we have very useful guidelines that we stick to give us the idea of what we need to give as treatment. But on top of that, apart from the inhalers, which have a massive help, pulmonary rehab is a big thing that we would actually talk about. So I'm not suggesting that you end up running like this gentleman, but actually it would be a course of a few weeks, normally speaking without COVID, where it would be face-to-face, and you would actually be assessed as to exercise tolerance, and then given exercises to do each week, and be encouraged to push your lung function and actually able to manage breathlessness, learning about how to pace yourself and how to actually improve lung function or make the most out of it. And alongside that, there is a lot of good educational material that occurs in the pulmonary rehab courses. So I would always encourage those, and often at the moment they're online. On top of that, flu and pneumonia jab. So the flu jab is usually is every year, seasonally, sort of September, October time. And I would really recommend that people with COPD would have that to protect them, because obviously they're more vulnerable, and if they get flu, then they're going to be a lot more seriously ill than other people. The pneumonia jab is a one-off for life under most circumstances. And again, I would recommend that very strongly. There is right sort of at the specialist treatment intervention, oxygen assessment or lung surgery or lung assessments in different ways, and there are different interventions that can be given if someone is very, very severely unwell and exhibiting a lot of breathlessness. Next slide, please. So self-help. So that alongside the flu jab and the inhalers and trying to manage your condition in that way, probably the single most important thing would be to stop smoking. There is a graph that I wasn't able to present to you for copyright reasons, but it shows that as we get older, our lung functions all deteriorate, which is natural. But if you smoke, the deterioration is much more severe. But if someone stops smoking, although your lung function won't go back up to a non-smoker's lung function, it will tail off much more slowly and the deterioration will be much slower. So I always say to people, it's never too late to stop smoking, and it is always valuable to do that. So that would be a big push. And there are all sorts of ways that you can get help with stopping smoking. Staying active, staying well. So those two things, British Lung Foundation, I'll show the link at the end, but they have lots and lots of enormously useful information on exercises that you can do. But really, it doesn't have to be a certain exercise. If people can't do ones that involve a huge exertion, you can do seated chair exercises. But equally, if you're able to, going for a walk, cycling, whatever else, something that you're going to enjoy doing. So it's actually going to be good for your mental well-being, but also will help you with your lung function, and that will help you maintain your lung function. And alongside that, staying well. So really important that you actually, have those jabs, but also as much as you can avoid getting unwell. And I'll talk a little bit about what to do if you do become unwell. Pacing yourself as well. I've got a link at the end as well about how to pace yourself. There are certain ways that you can manage going upstairs and other exercises if you're having to lift something and so on, breathing through it. Breathing exercises, and alongside that, sing and breathe, of course, where we teach people to do diaphragmatic breathing from your tummy. And actually that's really vital. And alongside that, I know you had a physio who was in contact with you, who did a session, and she said she was going to be teaching you all about how to manage your breathing, but also how to bring up sputum. So I told you I would speak about sputum, but that's really important when some people really struggle with this. There are ways of helping with that as well. Eating well, keeping a healthy weight. We know that with some people, they can actually become malnourished because it takes up a lot of energy. If you're very breathless, you actually use up a lot of energy. And so some people, then we would actually advise that they have a very high calorie diet in order to maintain their healthy weight. Obviously, if someone's very overweight, we would encourage perhaps losing a bit of weight so that you're not then putting extra weight when you're exerting yourself. Mental health and well-being is really important as well. So actually exercise comes into that produces endorphins that make you actually feel better, but also reaching out to other people if you're struggling, and seeking support from friends and family and from health professionals. So I would really urge people to do that. And as I said, keeping well and managing other conditions. A lot of people with COPD have other long-term conditions, for example, some forms of heart problems, and many other problems as well, diabetes and so on. So it's sort of juggling that and managing that all together, and would need to seek help from your health professional. Next slide, please. So alongside that, this, again, thanks to the British Lung Foundation, but certainly every practice nurse would be encouraged to give their patients a management plan that is tailored to you. Now, the British Lung Foundation have these that actually have lots and lots of extra information in. We would perhaps give slightly simplified ones from the practice, but this would actually complement the British Lung Foundation one. and really knowing when to seek help. So people who have COPD can be more likely and more vulnerable to getting chest infections. And we would often give rescue medication, which would consist of antibiotics and oral steroids, so steroid tablets, with a very clear action plan as to when you should start taking them, and also to contact your surgery when you are taking them so that we can follow you up. So that was what I would normally say to my patients. But actually, it's actually catching it early, and a lot of people tend to, especially older people who've been used to being very independent perhaps and not relying on people, don't want to bother their health professionals. But in this instance, we would say, please do contact us early and seek help early. And if you're not sure whether you should take any medication, please ask us. And that's really important, that we get on top of it early, and we want to avoid hospital admission as much as possible. Okay, next slide, please. So I've got this lady, living well, preparing for the future. I attended a Parish Nurse symposium recently, and there was someone talking about aging well, and so I've given the link there to some of the public talks that she has done. And actually, I do believe that people can look after themselves really well and age well. And so mostly the things that I've talked about healthy ways of living, exercise, and eating healthily, and looking after your mental well-being, all those sorts of things are encompassed in this. But I just thought that you might find that interesting. The other thing that we may discuss, and in a parish nurse role I would perhaps have a little bit more time to talk about, would be something called advanced care planning. And it's really talking about what your wishes would be for the future. And actually, this is a good thing for everyone to do. It's not just waiting till you're really ill to do this, but actually thinking about if you would like to have hospitalization if you're unwell. And obviously in the early stages, one would say that that would be a good idea. But, you know, perhaps later on in life, people may get to the point where they think, no, they don't want so many interventions. But all this sort of thing is really useful to talk about, particularly when you're well, and you don't have to, it's not an emotional thing. But actually, I think it's really important that one prepares ahead of time, so that you know, it's not a shock to anyone, and actually you have frank conversations with family and friends about all this sort of thing as well. Alongside that, as a parish nurse, I have the privilege of being able to talk to people about spiritual care as well. And the importance of being a whole person. We are a body, mind, and spirit, and those three things come together and all affect each other. And so what I would like to say is that if anyone would like to pursue that with me, I can actually refer people to our pastoral care team, or myself if you need extra support in any shape or form. But certainly that's something that maybe people don't talk about very frequently, but it may be something that you want to explore. Next slide, please. So these are the useful links. I won't go through all of them with you, but British Lung Foundation and sort of nutritional pathways for people. Also looking after yourself in the cold weather. That's something I didn't really go into in detail, but there are some tips there as to how to protect yourself and look after yourself. And then shortness of breath positions and pacing and all those sorts of things, and how to bring up sputum easily and so on. One thing I didn't mention when I talked about the inhalers was that how important it is to actually get really good advice on how to take your inhalers properly. If you're given them and you haven't been told how to take them, please pursue it. On Asthma UK website, there are wonderful videos on every sort of inhaler that you can imagine. Every device is there. So you can look up these videos and they will show you how to use them properly. If you're given them and you're not using them properly, then they won't be effective. So just a tip. Next slide, please. So these are my details, and Liv will send them around to everyone anyway, for if anyone wants to contact me. Okay, and then the last slide, please. So this is just a little bit about parish nursing services. So everywhere at the moment except Wales, there are parish nurses. But I think they're hoping that there will be some nurses who will want to expand into Wales as well. There are about 88 nurses in the UK at the moment, many more in other countries, and they may be called faith nurses instead. But in the UK, we call them parish nurses. And so I am affiliated to the Parish Nursing Ministries UK, and have to have done their training. I also have to maintain my registration as a nurse in order to do this work. Overall, about 75 services, so some nurses actually work with each other and in combination in teams. But I believe there are about 12 new ones who've just done the training who will be joining this MAP as well. Yes, we really are filling in the gap where perhaps the NHS doesn't have the time to speak to people and explain things. I could be an advocate for people when they go and see their GP or other health professional, signpost to other agencies, or walk alongside you with whatever condition you're dealing with. So many thanks for listening. We'll hand over to Liv now and for any questions. Thank you.